Local anesthesia, greater Palatine block. The equipment needed for this procedure is as follows: personal protective equipment, syringe, 27-gauge short or extra short needle, gauze, anesthetic cartridge, topical antiseptic, optional, topical anesthetic, cotton tip applicator, and hemostat or cotton pliers. The greater Palatine, or GP block, is used during dental procedures that involve more than 2 maxillary posterior teeth distal to the maxillary canine. This maxillary block anesthetizes the posterior hard palate, anteriorly as far as the maxillary first premolar and medially to the midline, as well as the lingual gingival tissue in the area. Because the GP block does not provide pulpal anesthesia of the area teeth, the use of the ASA, PSA, and MSA blocks, or the IO block, may also be indicated, especially during non-surgical periodontal therapy, because dentinal hypersensitivity is possible when you are instrumenting exposed root surfaces. The landmarks are the maxillary third molar, the junction of the maxillary alveolar process, and the posterior hard palate, and the greater Palatine foramen. The deposit location or target area for the GP block is anterior to where the greater Palatine nerve enters the greater Palatine foramen from its location between the mucoperiosteum and palatine bone of the posterior hard palate. The greater Palatine foramen is usually seen as a depression on the palatal surface at the junction of the maxillary alveolar process and posterior hard palate, at the apex of the maxillary second molar in children or third molar in adults, approximately 10 millimeters medial and directly superior to the lingual gingival margin. In a patient who has a vaulted palate, the foramen appears closer to the dentition. Conversely, in a patient with a more shallow palate, the foramen appears closer to the midline. Load the local anesthetic syringe as demonstrated in the procedure loading the metallic or plastic cartridge type syringe. Before injection, follow all steps as demonstrated in the procedure basic injection technique. Assume the correct operator position for a right-handed clinician at 8 to 9 o'clock, right side, or 11 o'clock, left side, and a left-handed clinician at 4 to 3 o'clock, right side, or 1 o'clock, left side. Ask the patient to open his mouth and extend the neck either to the right or to the left. Locate the greater Palatine foramen by gently sliding a cotton tip applicator along the hard palate surface, beginning at the junction of the maxillary alveolar process and the posterior hard palate foramen near the maxillary first molar, and moving distally until the cotton tip applicator falls into the depression of the greater Palatine foramen. Usually, the foramen is located near the maxillary third molar, although it can be located anterior or distal to this area. Be careful not to cross the more yellow-tinged soft palate with the applicator, which will induce gagging. Prepare the tissue with topical anesthetic slightly anterior to the greater Palatine foramen. Dry the tissue to remove any excess topical anesthetic. Using a 27-gauge short or extra short needle with the syringe in the dominant hand, orient the bevel of the needle toward the hard palate. Establish a fulcrum that allows you the greatest stability of the syringe. Using a new cotton tip applicator in the non-dominant hand, apply firm pressure at the greater Palatine foramen. The use of pressure anesthesia with a cotton tip applicator to the injection site before, during, and after the injection to blanch the tissue will reduce patient discomfort. Direct the syringe from the contralateral side of the mouth at a 90-degree angle to the palate toward the cotton tip applicator, with the large window facing you. Insert the needle slightly anterior to the greater Palatine foramen, approximately 3 to 6 millimeters, until you contact the palatine bone, with the needle bowing slightly, while maintaining pressure on the foramen with the cotton tip applicator. Aspirate by pulling the thumb ring back gently on 1 to 2 millimeters at the injection site to prevent the possibility of an intravascular injection. If the aspiration is negative, slowly deposit approximately 0.45 milliliters of solution, 1/4 of the cartridge, over approximately 20 to 30 seconds. Tissue in the area will blanch even further when the anesthetic is administered. Carefully withdraw the syringe and immediately recap the needle using the one-handed scoop method with a needle sheath prop or other recapping device. Rinse the patient's mouth and wait approximately 3 to 5 minutes until the anesthesia takes effect before beginning treatment. Complications from this injection are rare. However, some patients may become uncomfortable and may gag if the soft palate becomes inadvertently and harmlessly anesthetized.